Hi there. This is a short presentation on clinical judgment model. This is the model that the Mount Aloysius College Nursing Department is going to be moving to in the fall of 23 semester. Previously, you had learned nursing process whenever you apply that to your clinical patients. However, you're going to notice that there were some problems with that model that made it more difficult, more challenging to work with. And therefore, we're moving towards this clinical judgment model, which you're going to find is more realistic. It's more in line of what you actually do at clinical with your patients. It translates better into other disciplines when working with other disciplines in the healthcare setting. And maybe most importantly, this is the model that the NCLEX licensure exam has moved towards in their testing procedure. Whenever you're presented with a client scenario, a client case, they expect you to demonstrate some clinical judgment and knowing how to work with that client. So for those reasons, we've made the decision to move into this clinical judgment model, but we need to kind of walk you through what the transition from nursing process into clinical judgment model actually looks like and how you go about doing that when you go to clinical. So to begin, we're going to go ahead and look at this short clinical case that we will use to apply both processes, the nursing process, then the clinical judgment model, so you can see each and how that transition actually works. So this was a 65-year-old female. She presented through the emergency department with complaints of lightheadedness whenever she stands up. She appears pale. She appears diaphoretic. You note that she gets unsteady whenever she stands up to her feet. Her lung sounds are clear. Her heart rate's regular. Her peripheral pulses are rapid and thready, very weak. Her pupils are equal, round, reactive to light. She has no peripheral edema. Her appetite's good, and her last BM was yesterday. She had a past medical history of anxiety and type 2 diabetes. Her prescriptions, she takes alprazolam, Xanax as needed for the anxiety, and she takes metformin, glucophage to manage her diabetes. Lifestyle, she denies any smoking, denies alcohol use, denies using any recreational drugs, and she does admit that she's a vegetarian. Her vital signs, 37.4, heart rate was 116 in regular rhythm, a respiratory rate was 20, blood pressure 92/54 with a pulse ox of 95% on room air. Here's a picture of your client. They did a metabolic panel, they did a CBC, and then some other diagnostic studies while she was in the emergency department. You look at the metabolic panel, sodium 141, potassium 4.6, chloride 102, CO2 23, BUN of 13, creatinine of 0.8, glucose of 132. This would be a random glucose in the emergency room, not a fasting glucose. So all of those electrolytes are within normal limits, nothing significant there. They did a CBC on her. The white blood cell count looks good at 8.8. Hemoglobin and hematocrit, however, you notice both of those are low at 7.6 and 35 with an MCV of 86. That's in the normal range. So her H and H are low for some reason, but the size of the cells is good, which helps us identify what the cause of that low H and H is. Platelets are normal at 341. Urinalysis was a clean sample, a clear sample with a specific gravity of 1.018. Bacteria was negative, so it's basically a clean urinalysis, no UTI. And that kind of correlates with our white blood cell count that was within normal limits at 8.8, and the fact that she doesn't have a fever. So that all looks good. Urine drug screen was negative, which means she didn't take any recreational drugs, which is consistent with what she told us. She doesn't use recreational drugs, and it also tells us she hasn't used her Xanax lately, that she's allowed to take as needed. So that's all good information to have. Her lactate was negative at 0.7, which lets me know that she's not hypoxic. She doesn't have sepsis, none of those other kind of things that could be going on with her. Her thyroid function is normal. TSH was 2.1, free T4 thyroxine level was 1.07. So those are normal, and her alcohol level was negative, so she wasn't inebriated when she came into the emergency department either. They did a CT of her head because some of the symptoms she showed up with could be symptoms of a stroke, so let's rule that out. They did a CT of the head. It did show some old ischemia in her brain, so maybe she had a previous stroke. Maybe she was even unaware of that. And some chronic degenerative changes. She is a 65-year-old, but there's no evidence of any acute changes, so she has not had a stroke today. So that's our case study we're going to be working with. Now, the old model that you learned was the nursing process. The first step of the nursing process was always to assess, um, gather your data, recognize some important things, um, to try to see a picture emerge of a problem, which then you move into step 2 of the nursing process, where you identify those problems, give it a name, give it a label, give it a nursing diagnosis, one of those NANDA approved nursing diagnoses that you're allowed to, as a nurse, assign to a client. Once you have that nursing diagnosis, that identified problem, then number 3, you move on to the planning stage, where number 1, you plan a goal, which is the eventual destination you'd like your client to arrive at. It's basically the opposite of whatever the problem you identified was. In order to get him to his goal, you're going to plan out some interventions, some things that you're going to do working with him to try to help him to get to that eventual goal. And then you're also going to plan out some outcomes and some checkpoints that you can evaluate along the way to see if your interventions are effective at helping him to get to his eventual goal. When it comes to those outcomes, remember, you want to make those SMART, S-M-A-R-T, specific, measurable, which means objectively measurable, something that we would all evaluate the same, appropriate, which means you've got interventions in place that will help him get to meeting his outcome. It's realistic, something that he can actually accomplish and shows a positive improvement, and a time frame. When do you want the evaluation to occur? So S-M-A-R-T. Number 4 step of the nursing process was implement, go and do those things that you planned on doing with him. And then number 5, evaluate, is you go back and look at those outcomes at the expected date, at the expected time, and do an evaluation. Is the client meeting that outcome? Is he getting where you expected him to? Is he partially meeting? He made some improvement, but not quite where you expected him to be at this point. Or unmet, he's made no change whatsoever. If your evaluation was either partially met or unmet, then you need to go back and make some revisions to your care plan in order to try to help him be able to meet those outcomes that you had formulated for him. So that was the nursing process. Now, if we were to apply that nursing process to the case study that we looked at earlier, then in our assessment, we recognized some significant data, such as the patient was complaining of having lightheadedness whenever she stood. She looked pale, she looked diaphoretic, she was unsteady when she got to her feet. Her peripheral pulses were very weak and thready. She was a vegetarian. Her hemoglobin was 7.6, her hematocrit was 35, both of those were low. Her MCV was within the normal range at 86. Blood pressure was low at 92/54, heart rate was rapid at 116. We recognized those and kind of put everything together and came up with a NANDA-approved nursing diagnosis of impaired tissue perfusion. And we need to put together a plan to help address this impaired tissue perfusion that our client demonstrates. So the goal that we're going to come up with is we'd like our patient to have improved tissue perfusion. How are we going to get there? We're going to plan some interventions. We're going to put some safety measures in place. We're going to check her orthostatic blood pressure every shift. We're going to encourage some fluid intake. We're going to teach her about some high protein vegetable sources because she is a vegetarian. And the MCV being normal, with the low H&H, lets us know that protein may be an underlying problem with this low H&H. So let's teach her some high protein vegetable sources, monitor hemoglobin, hematocrit, and encourage her to make position changes slowly because, again, I'm worried about safety with her. I'm going to plan out some outcomes, some checkpoints that we can evaluate along the way to see if our interventions are helping her get to her eventual goal of having improved tissue perfusion. So we came up with 5 outcomes. Number 1, we're going to have the client dangle at the bedside for at least 60 seconds prior to standing every time she gets out of bed. We're going to the client's systolic blood pressure will not drop by any more than 10 millimeters of mercury upon standing whenever we check her orthostatic blood pressure. The client will drink a minimum of at least 2,000 milliliters of fluids every day. The client will be able to name at least 3 high-protein vegetable sources to include in her diet as a vegetarian after completing our teaching with her. And the client's hemoglobin will be greater than 9 within 1 week as we're checking that. Number 4, implement. We're going to go and do those interventions we planned. Evaluate. We're going to come back and look at those outcomes at the date, at the time frame that we established to try to see if she's either meeting, partially meeting, or not meeting. And if she's either partially meeting or not meeting, we need to go back and make some revisions. That's the way the nursing process would have worked if applied to that case study that we just looked at. So to talk about clinical reasoning, clinical judgment, clinical reasoning has been defined as the process by which nurses collect cues, process that information, come to an understanding of what a patient problem or a situation may be, plan and implement some interventions, evaluate outcomes, and then reflect on and learn from that entire process to maybe make some changes if we would need to and apply that again in the future to similar cases. Moving then into clinical judgment is the skill of recognizing those cues about a clinical situation, generating and weighing some different hypotheses. What all could it be? There could be a lot of different things out there, and coming up with a list and prioritizing what all those could be. What's the most likely thing? It probably is. Taking some actions, evaluating the outcomes for the purpose of arriving at a satisfactory outcome. Clinical judgment is the observed outcome of two unobserved underlying mental processes, both critical thinking and your decision making. And like I said, it's this clinical judgment that now the National Council is testing more on the licensure exam from you. So we want to teach you, we want to get you used to applying your clinical skills in this fashion. So to do that, we have moved into what's known as the clinical judgment model. Now, the clinical judgment model is 6 steps. Number 1 is recognizing cues, gathering information. It's elements of your assessment and data that provide important information, recognizing what data are relevant versus irrelevant, identify relevant information first to help determine what is most important. So this is your assessment data. This is your lab data. This is your vital signs. This is your patient's past medical history, his lifestyle choices, his family history, all of that assessment data, both subjective and objective, that's going to help you be able to recognize some cues. Once we've gathered all that data, we move into number 2, analyze those cues. Consider cues in the context of the patient history, his presentation, and what is significant to you, what jumps out at you as maybe being relevant, significant data. Number 3, you're going to come up with a list of hypotheses, all the things you think it possibly could be. Consider all the possibilities, determine their urgency and the risk to the patient. You're going to prioritize those. What is the most likely thing it probably is? And then what are some of the possibilities but least likely in this scenario? Come up with a list, prioritize. What is the most likely thing it probably is? Which again is very realistic. That's what we do in practice. Number 4, generate some solutions. Use the hypothesis to develop some expected outcomes. What interventions will help to lead you to those expected outcomes? Number 5, take action. Use your nursing interventions to go and implement those, address the highest priorities of care, indicate how they're going to be performed. This includes all of those interventions that we've talked about previously, your assessments, your teaching, your documentation, collaboration, everything that needs to be done to help this person overcome that problem that you identified. And then number 6 is just evaluate those outcomes. Consider your patient outcomes in relation to the expected outcome. So basically, your patient outcome is what is your patient doing, and then compare that to the expected outcome. What do they expect him to be doing, and is that showing some improvement? Is it showing a decline, which we don't want, or is he unchanged, which is not really ultimate either. And again, if your patient's declining or if he's not making any improvements, we'd like to correct that, and so we're probably going to make some revisions to our plan and go back and do that. So the nursing process translating into this clinical judgment model that we're going to be doing, that process of assessment in the nursing process fits into the recognizing and analyzing cues parts of the clinical judgment model. In the nursing process, we then made a diagnosis, that NANDA approved nursing diagnosis. The problem with that is nobody else uses that NANDA nursing diagnosis. Whenever we look at our client and we say that she's getting lightheaded when she stands up or H&H is low, most people are going to look at her and say she's anemic. They're not going to say she has impaired tissue perfusion. When a patient comes in showing signs of a stroke, he can't move half of his body and he's mumbling and talking incoherently, they're not going to say, oh, it appears to me as if this patient has impaired cerebral tissue perfusion. They're going to say it looks like he's having a stroke. When the patient comes in having mid-sternal crushing chest pain, diaphoretic and anxious and nauseous, they're not going to say it appears to me as if he's having impaired cardiac tissue perfusion. They're going to say he's having angina. So that nursing process, that diagnosis, those NANDA diagnoses, it's just not realistic. It's not what we do in practice. And when we talk to the physical therapist, when we talk to the physician, when we talk to the dietitian, nobody else uses that terminology. So therefore, we've gone to this clinical judgment model where when we get to that stage, we kind of prioritize our hypotheses. What are all the things it possibly could be? So yes, it could be anemia, but it could also be signs of a stroke. It could be that he's hypoglycemic. It could be that he's just deconditioned and he's not used to getting out of bed. Now when she gets out of bed, she gets dizzy when she stands up. So it could be multiple things that we're going to prioritize that list and figure out what's most likely and then come down to the end where, hey, here's the least likely thing that it could be. Maybe she's growing a brain tumor and that's why this is happening. Not very likely, but it's on my list. It could be a possibility. So we're going to come up with a list of all these hypotheses of things that I think it could be. This is also known as a differential diagnosis. All the things we think it possibly could be. In the nursing process, then we would move to planning. What we call that in clinical judgment model is generating solutions. Where we make our outcomes, where we expect the client to get to. In the nursing process, then we would move into implementing, go and do our plan. In the clinical judgment model, we call that taking action, do those interventions. In the nursing process, we would move into evaluating, where we evaluate our outcomes. In a clinical judgment model, that is still the same thing. We still evaluate our outcomes to see if we're progressing the way that we expected him to progress. We don't want him to be declining. We don't want him to be unchanged. We want to see some progress in our client. So we're going to evaluate those outcomes to see if we're showing some progress. Now, to apply that clinical judgment model to our previous case study that we looked at previously, number one, the first step is recognizing cues. This is where we're going to list all of our assessment findings, everything that we found with our client. We're also going to list out all of our laboratory results, all of our vital signs, patient's family history, her past medical history, all of her lifestyle factors. We're going to list all of that out to be able to recognize cues. So this is all the assessment data, subjective data, objective data, everything falls into this. We're going to look at all of that. And number two, we're going to start to analyze some cues. We're going to recognize some significant data, basically. What falls outside of the norm that would be that would allow us to recognize some problems. So with our client, we analyzed all of that data and we recognized that there were some significant pieces there, like her, she was complaining of having lightheadedness when she stood up. She got unsteady when she stood up. She looked pale. She looked diaphoretic. Her peripheral pulses were very weak and thready. Her hemoglobin was low at 7.6. Hematocrit was low at 35. Her MCV was normal at 86. So it's going to be one of our causes of having a normocytic anemia. Her blood pressure was low at 92/54 with a rapid heart rate of 116, and it was regular, which would be important to note as well. So we come up with our hypotheses, all the things that we think it possibly could be. Again, this is kind of our differential diagnosis and prioritized. Number one, I'm seeing anemia. Basically, all of these significant assessment findings, they all point towards anemia. Everything there could be anemia. Number two, it could be dehydration. However, not everything fit dehydration. If you remember our BUN, our creatinine, those kind of things, the hematocrit, none of those things really point towards our sodium level, don't point towards dehydration. So it's a possibility, but it's less likely. Maybe she's deconditioned, so that's on my differential diagnosis. Maybe she's hypoglycemic, it could be, but again, if you remember, I looked at my metabolic panel, her Glucose was within normal range, so I don't think it's hypoglycemia. It could be a stroke, a CVA, but I don't think it's a stroke because her CT scan was negative and not all the assessment findings really fit stroke. It could be AFib, but again, less likely. I don't think it's AFib because, for example, her heart rate had a regular rhythm, so I don't think it's AFib. Hypothyroid, it's on the list. It possibly could be that, but I really don't think it is because her TSH was good, her T4 level was good. So I come up with a list of all the things that those symptoms could be produced by, and then number one, what do I think explains everything on that list? What's the most likely scenario? And for me, I think she's anemic. Clinical judgment model, I move to number 4. I generate some solutions. I come up with some outcomes. Again, SMART. Number 1, I'm going to have the client dangle at the bedside for at least 60 seconds before she stands up to her feet every time she gets out of bed because I'm worried about safety. The client's systolic blood pressure will not drop by any more than 10 millimeters of mercury whenever she does stand up to her feet every time that I check that orthostatic blood pressure on her. Number 3, the client will drink at least a minimum of 2,000 milliliters every day to keep her fluid volume up. Number 4, the client will name at least 3 high-protein vegetable sources since she's a diabetic to include in her diet after we teach her about high-protein sources in vegetables. And number 5, the client's hemoglobin will climb up to at least 9.0 within 1 week after doing all these interventions. Number 5, take action. We're going to go and do all these interventions. We're going to implement those safety measures. We're going to assess her orthostatic blood pressure every shift. We're going to encourage fluids. We're going to teach her about high-protein vegetable sources. We're going to monitor her H&H. We're going to encourage her to make position changes slowly. And then on those time frames that we established, we're going to evaluate those outcomes. Are they showing some improvement? Are they showing a decline? Or are they unchanged? So basically, this is how we would apply that clinical scenario using the clinical judgment model, which is very similar, but with some key differences there to nursing process. And again, this is more realistic, and this is exactly what the National Council is now testing you on your licensure exam. They're applying it more this way. They want you to consider all the things that possibly could be. Identify what's most likely, what's least likely. And that's exactly what we're doing in practice anyways. So this is more realistic. Now, as far as clinical paperwork, we have the clinical judgment model clinical concept map. And that's what this would look like. So you do have an example of this that will be posted for you as well. And whenever you go to clinical, you'll be completing one of these on your assessment findings. So this is how we would take all those assessment findings from the case study that we just looked at, and we would fit it into this concept map. And this is what you would complete for clinical and turn into your clinical instructor. So that's what this looks like. The formatting looks a little weird because I put it on the PowerPoint slide for you, but this is also posted for you that you can see. And so this, very briefly, very quickly, just kind of walked you through taking a clinical case whenever you go to clinical and work with your client, and you write down all of his data. You look up his labs, you get his vital signs, you look up his diagnostic studies, you look up all that data, and do your assessment on him, how you're going to be able to complete this clinical judgment model on your client. So hopefully that helped a little bit to walk you through it, to be able to see it and apply it to an actual case. And you'll be working with this with your clinical instructors throughout the semester and as you go. So thank you very much.